Bismillahirrahmanirrahim. Deep fungal infections. The deep mycoses, there are thermodimorphic fungi that is converted from the mold saprophytic form into the parasitic form, the yeast. They are inhaled by the lung, except sporotrichosis, which is inoculated. So it is from saprophytic form molds into, with increasing temperature in vivo, it's converted into the parasitic form to a yeast form. Also, they are the deep mycoses with the sporotrichosis. But now I will start with first the subcutaneous mycoses. The subcutaneous mycoses, including also the sporotrichosis. So the subcutaneous mycoses, they include the sporotrichosis and the chromoblastomycosis or chromomycosis and the phaeohyphomycosis, the subcutaneous type, and the mycetoma. The most important is the sporotrichosis and mycetoma, the subcutaneous mycoses, especially sporotrichosis and mycetoma, we will talk about first. So the subcutaneous mycosis, it is infection of the subcutaneous mycoses, mainly through trauma and inoculation, spores into the skin, leading to appearance of primary cutaneous lesions on exposed sites like feet, lower limb, the site of trauma. As we said, the most important is the sporotrichosis and mycetoma. First, we will talk about the sporotrichosis, etiology, epidemiology, clinical features, diagnosis, and treatment. The sporotrichosis is a chronic lymphatic subcutaneous fungal infection. It is a chronic lymphatic subcutaneous fungal infection. The cause is Sporothrax schenkii. The etiology is the Sporothrax schenkii. It is a dimorphic aerobic fungus found in soil, introduced into the skin by trauma and direct inoculation. Incubation period 1 to 3 weeks. Epidemiology occurred in tropical areas, especially South and Central America, Egypt, Australia. Occurs in adult males and occupational, usually with mine workers, florists, and gardeners. This is the etiology and epidemiology. The clinical picture of the sporotrichosis is there is the cutaneous form and there is the extracutaneous form. The cutaneous form, the most important, is lymphocutaneous varieties, the commonest. It follows an implantation of the spores in a wound leading to sporotrichotic chancre, which occurs in exposed skin as the upper limb, as a nodule or pustule that breaks down into an ulcer. Involvement of lymphatics occurs proximally, leading to a chain of lymphatic nodules that soften and ulcerate and are connected by hard lymphatic cords. The regional lymph nodes rarely become swollen and may break down. The primary lesion may heal spontaneously, leaving the lymph node enlarged. There is good general health. Differential diagnosis from Mycobacterium marinum and Leishmaniasis and others. The endemic fixed variety, the pathogen remains localized at the point of inoculation, forming either acneiform, nodular, ulcerated, or verrucous, or infiltrated plaques. This reflects high immunity of the patient. This is the cutaneous forms. The extracutaneous form may follow inhalation of the patients with defect in host defense, like alcoholics and AIDS patients. There is ulcerated nodules on the skin, and mucous membranes and visceral lesions may occur. The diagnosis, there's a question in diagnosis, how to investigate a case of sporotrichosis or the mycological diagnosis of sporotrichosis. So there is a direct KOH, it's of no value, and as the organism is few in number. Fluorescent antibody technique may detect the pathogenic phase in vivo, and culture. But the most important is culture on Sabaro agar. At room temperature, there is compact moist white with wrinkled surface. Later, aerial mycelium is found and colonies become darker. First, it is moist white, then the colonies become darker. Microscopically, there is narrow hyphae with small oval triangular or triangular conidia. Narrow hyphae with small oval or triangular conidia. This is the culture on Sabaro. The histology, the biopsy by hematoxin, eosin, and PAS, there is granulomatous reaction with foci of necrosis. It is present as small cigarette-shaped or oval bodies that may be surrounded by thick, radiate eosinophilic substance, forming asteroid bodies. This is the diagnosis, mostly by culture and biopsy. And the treatment, spontaneous remission may occur, but we give potassium iodide, first 5 drops initially, increasing to 50 drops 3 times per day, continued for 3 to 4 weeks after clinical cure. Also, itraconazole, Sporanox 100 to 200 milligram daily is effective, and amphotericin B, or miconazole intravenously. This is the sporotrichosis, and we can see here, this is a picture of sporotrichosis, the ulcerated nodule with proximal lymphangitic spread. So we will say again in this diagram, the subcutaneous mycosis, first the sporotrichosis, and then we'll talk about the mycetoma also. The sporotrichosis, the organism is Sporothrix schenkii. Infections occupational, florers and gardeners' mines, and there is first there is a nodule that may ulcerate, forming a chain of lesion along lymphatics. Clinical picture, the most common, of course, this is the lymphocutaneous type. There is important differential diagnosis here is the sporotrichoid lesions, sporotrichosis, leishmaniasis, atypical mycobacteria, and leprosy. Sporotrichosis, leishmaniasis, atypical mycobacteria, and leprosy. Now this is the mycological investigation in the case of sporotrichosis, KOH and culture, and biopsy granulomatous H1E, and also we can make PAS stain. Treatment, potassium iodide, saturated solution of potassium iodide, also azoles, ketoconazole, and itraconazole, and fluconazole, and heat treatment. And this is the sporotrichosis. This is a picture of chromoblastomycosis, another subcutaneous mycosis. The mycetoma, also the second or the third here, the subcutaneous mycosis, is the mycetoma or Madura foot. The mycetoma or Madura foot, it is a tumor produced by fungi characterized by localized swelling with severe affection of subcutaneous tissue and bones of the feet and hands, formation of draining sinuses, and granules of different colors are discharged. Etiology, 2 main groups, either eomycetoma or actinomycete. The eomycetoma, they are fungi, incubation period 20 years, and the actinomycetes, they are bacteria and incubation period 5 years. The different causative agents with different colors of grains. The organism occurs as saprophytes in the soil with infection of subcutaneous tissue of the skin, occurs through penetrating injury. Epidemiology occurs in tropical and subtropical, especially adult male who work barefooted. And the clinical picture, lesions commonly occur in the foot or lower legs at the site of trauma with slowly progressive firm painless nodules with irregular lumpy appearance which break down and discharge pus containing grains of different color through multiple sinus tracts. Extension to the underlying bones and joints may lead to periosteosis, osteomyelitis, and arthritis. This is why radiologic studies are very important in mycetoma case. And the diagnosis is by direct KOH of the pus. Color of granules determine their fungal or actinomycete nature. Of course, very important to make the culture, fungus culture and bacterial culture. The fungus only with chloramphenicol only at room temperature. Growth occurs within 5 to 10 days, and actinomycete with chlorhexamide only at room temperature. Growth occurs with 2 to 3 days. Histology, there is chronic granulomatous reaction with abscess formation containing the characteristic granules and dense fibrosis. As we can see here, this is the histology with H&E stain, and also as we can see, direct KOH of the pus, culture, fungal and bacterial, and with the histology. The treatment is excision of localized lesions The actinomycetoma, I give antibiotic, dapsone with streptomycin, or sulfamethoxazole, trimethoprim plus streptomycin or rifampicin, amikacin, and eomycetoma we give ketoconazole, itraconazole, or graziofulvin. So either I give antibiotic or antifungal according, of course, to the culture results. This is the mycetoma, and here we can see pictures of the mycetoma. Another picture, eomycetoma, and mycetoma. And this is, as we said, the histology of the mycetoma. Now we will see another diagram of the mycetoma or Madura foot. Occurs in bare-feeted persons, either actinomycetes, which are anaerobic filamentous bacteria, or the eomycetoma, which is caused by fungi. Clinical picture: painless nodules, granulating lesions, sinuses discharging granules, according to the color of the organism. Differential diagnosis from botryomycosis. It is caused by Staph aureus, and of course the treatment occurs 1 year treatment. The diagnosis is by culture and biopsy. The culture is either bacterial, aerobic botryomycosis, or anaerobic actinomycosis, and Sabaro agar with chloramphenicol only, no cyclohexamide, because it inhibits the growth of mycetoma. The biopsy, as we said, H&E, and sometimes special stains, PAS and Gram. We can see here the histopathology. Colon is surrounded by polymorph nuclear leukocytes. And X-ray is very important for bone affection. So the diagnosis is culture, biopsy, and X-ray, very important. The treatment of eomycetoma, of course, according to the culture. If it is bacterial, I give the antibiotic, as we said, and if it is the fungal, we give the eomycetoma, we give systemic antifungal, amphotericin B intravenously, or the new antifungals, Sporanox, itraconazole, and ketoconazole, and if there is bone affection, sometimes we need amputation. Of course, we exclude bacterial. If there is it's bacterial, we give dapsone and streptomycin, or sulfamethoxazole, trimethoprim, and with streptomycin or rifampicin. This is the eomycetoma. And this is another picture of the pathology, a histopathological section of mycetoma. The deep mycosis, is they are thermally dimorphic fungi from saprophytic form. The molds into they are inhaled, except of course the sporotrichosis, which is inoculated. With increasing temperature in vivo, they undergo into the parasitic form, the yeast form. There are multiple deep mycoses. There is the blastomycosis, North American blastomycosis, coccidioidomycosis, histoplasmosis, and paracoccidioidomycosis. The etiology of the blastomycosis is blastomycosis dermatidis, and coccidioidomycosis is Coccidioides immitis. The histoplasmosis is Histoplasma capsulatum, and the paracoccidioidomycosis is P. brasiliensis. The etiology, usually they are inhalation of the spores from saprophytic source. Of course, the blastomycosis or North American blastomycosis from North America, adult male 30 to 50, and the paracoccidioidomycosis, the last one, is from Latin America, adult male 30 to 50. And for the coccidioidomycosis and histoplasmosis, They are from southwestern states of USA, and this is from tropical areas of Americas, all ages and both sexes. Clinically, primary pulmonary as pulmonary TB, maybe as they are inhaled first, so maybe asymptomatic, or there is lung symptoms, fever, cough, chest pain, and rarely erythema nodosum. When dissemination occurs, it in many organs as spleen, liver, bone, and skin, like ulcers, sinuses, etc. The primary cutaneous, which is rare, follows trauma and inoculation of the organism, leading to indurated nodules and lymph nodes. Of course, the paracoccidioidomycosis is different from blastomycosis by gum affection with loss of teeth and marked lymph node affection. The diagnosis by KOH biopsy, culture, and serological tests. KOH of the blastomycosis is thick-walled refractile cells with broad-based buds, and the paracoccidioidomycosis, it is rounded refractile cells with multiple budding. The coccidioidomycosis is large globular spheres with endospores, and the histoplasmosis, the KOH is negative, and there is intracellular budding yeasts. It is inside the histiocyte, and here we will see there is the differential diagnosis of the parasitized histiocytes, like also histoplasmosis, like leprosy, leishmaniasis, Donovan bodies, granuloma inguinal donovanosis, and rhinoscleroma. The culture, mostly they are mycelial white colony. The blastomycosis, mycelial white colonies produce small rounded conidia. Coccidioidomycosis or paracoccidioidomycosis, they are slower growing and fewer spores, and then blastomycosis. And the coccidioidomycosis, also mycelial white cottony colonies producing arthrospores along the length of the hyphae. The histoplasmosis, they are white cottony colonies with characteristic large rounded macroconidia. The caution, because the fungus is very or highly infectious, the serological of diagnostic value, and PPT antibodies is in 80% of cases. The treatment is ketoconazole or itraconazole. Amphotericin B intravenously also can be given in a dose of 0.4 to 0.6 milligram per kilogram per dose for 6 to 8 weeks by slow intravenous infusion. So we will talk again with this diagram of the North American blastomycosis and its organism is Blastomycete dermatitidis, and we can see here the broad-based, the thick-walled and broad-based buds of the KOH, and different from the South American or the paracoccidioidomycosis, which is rounded with multiple budding. Here we can see a picture of the blastomycosis clinically, Blastomycete dermatitidis, and another picture of blastomycosis also clinically. And here we can see another picture of blastomycosis clinically also. The KOH of the blastomycosis, we can see thick-walled refractile cells with broad-based buds, and here also we can see the same picture of the biopsy, thick-walled budding yeasts. So this is the first one, the blastomycosis, North American blastomycosis. The second one is we can see here the Coccidioides immitis, or the coccidioidomycosis clinically. And also we can see here the Darling's disease or the histoplasmosis clinically, caused by Histoplasma capsulatum. We can see here the histoplasmosis. The lesional biopsy shows dermal macrophage packed with dozens of tiny yeast forms of Histoplasma capsulatum. Of course, the KOH is negative, and there is intracellular budding yeast inside the histiocyte. You can see the yeast inside the histiocyte. And this is the differential diagnosis of intracellular parasitized histiocytes together with the histoplasmosis, which has the histoplasmosis capsulatum, no capsule, inside the histiocyte. The macrophage first comes into the organism, opsonization, internalization, lysis, and presentation. So this is present in histoplasmosis and also in leprosy, leishmaniasis, Donovan bodies, and granuloma inguinal, donovanosis, and rhinoscleroma. Leprosy, histoplasmosis, leishmaniasis, granuloma inguinal, and rhinoscleroma. So again, the deep mycosis caused by dimorphic fungi. They are mostly the blastomycosis, coccidioidomycosis, histoplasmosis, paracoccidioidomycosis, and sporotrichosis. They are thermally dimorphic fungi, exist in saprophytic form as molds in nature in soil in 25 degrees centigrade, producing infectious conidia that can be inhaled in all of them, affecting primarily the lung. Except sporotrichosis, it is inoculated into the susceptible host, and the temperature is increased to 37 degrees either in vivo or in the host or in vitro the media. The fungus changes into the parasitic form, except the yeast, except the coccidioidomycosis, where the parasitic form is in a sphere that produces endospores. The blastomycosis, North American blastomycosis, the etiology, blastomyces dermatididis, epidemiology, North American and African, adult male 30 to 40 years, commonly affected, clinical picture, primary pulmonary blastomycosis and primary cutaneous blastomycosis rare. The primary pulmonary, similar to pulmonary TB, it's asymptomatic, or there is low-grade fever, cough, hemoptysis, and sometimes erythema nodosum. Disseminated lesion may occur in other organs. On the skin, they are symmetrically distributed papular nodules on the trunk that may be ulcerate and discharge pus. Enlargement of lesions may lead to serpiginous outline with warty borders and central scoring. Primary cutaneous blastomycosis is rare. It follows trauma of the skin and anuculation of the fungus. Erythematous chancre appears after 1 to 2 weeks with lymphangitis and lymphadenopathy. And diagnosis, KOH examination of sputum, thick-walled, round refractile, spherical cells with broad-based buds. So it is thick-walled with broad-based buds. Culture at room temperature, white cottony colonies producing small rounded or oval conidia. The biopsy, histopathology, epidermal hyperplasia, inflammatory infiltrate with small abscesses, Langerhans giant cells contain the round or oval organism with thick rectile wall, budding form. Serological or precipitating antibodies in serum in 80% of infected cases of diagnostic value, and treatment amphotericin B, ketoconazole, itraconazole, intravenous miconazole. The coccidioidomycosis, the causative organism is Coccidioides immitis. The epidemiology, southwestern state of USA, it affects all ages and both sexes. Primary, there is the clinical picture, also the primary pulmonary, similar to TB but maybe asymptomatic, pyrexia, cough, and shortness of breath, erythema multiforme or nodosum, generalized maculopapular or maculoerythematous rashes can occur in 10% of cases. There is disseminated lesion, may rarely occur in immunosuppressed and AIDS patients. In the skin, abscesses, granulomas, ulcers or sinuses, bone joints and all organs. There is also primary cutaneous, which is rare, as firm, painless, indurated nodules occurring 1 to 3 weeks after local trauma with regional lymphadenopathy. The diagnosis, KOH examination of sputum or CSF, large globular spheres with endospores, large globular spheres with endospores. Culture also this is the histopathology also appears in the derms as spherules with endospores with PAS stain. The culture colonies are mycelial white cottony, also mycelial white cottony, and microscopy arthrospores produced at intervals along the length of the hyphae. Serological tests, example, precipitants and CF antibodies are of value of diagnosis. Treatment, amphotericin B, ketoconazole, and itraconazole, and caution, it could be culture, could be inhaled, and it is highly infectious. The histoplasmosis or Darling's disease. Histoplasma capsulatum, the etiology is histoplasma capsulatum. It is intracellular, parasitizing the reticuloendothelial system and involving spleen, liver, kidney, CNS, etc. The epidemiology in tropical areas of America, especially and Africa, it affects all ages and both sexes. Clinical picture, asymptomatic form with positive skin test with histoplasmine, and pulmonary form, it could be acute with fever, chest pain, cough, weight loss, etc. and maybe erythema multiforme or nodosum. Also, it may be chronic, affecting an adult, simulating pulmonary TB. The disseminated form may be acute, fatal, with prominent pulmonary signs, splenomegaly, lymphadenopathy, fever, mucocutaneous granulomas. This form is seen in AIDS patients and more skin affection. And it may be chronic manifestations of Addison's disease due to adrenal infiltration and large chronic mouth ulcers. The pulmonary cutaneous is very rare. It's after inoculation of the organism into the skin with nodule or indurated ulcer associated with local lymphadenopathy. The diagnosis is established by identifying small intracellular yeast-like cells of histoplasma in culture, histopathology, or even blood smear. Direct KOH of sputum yields negative result as the yeast is intracellular and destroyed by KOH. So the culture at room temperature, white cottony colonies with characteristic large rounded tubercle macroconidia. Caution must be taken as the fungus is highly infectious. Biopsy stained with PAS or Giemsa, the budding yeast are found inside the histiocytes. Of course, inside the histiocyte, intracellular. Histoplasmine skin test of no diagnostic value, serological test value of diagnosis. The treatment, oral ketoconazole and itraconazole. Paracoccidioidomycosis, etiology, Paracoccidioides brasiliensis. Epidemiology, Latin America, adult male 30 to 50% years are commonly affected. Clinical feature, pulmonary form with weight loss and chronic cough. Mucocutaneous form, severely painful ulcerating stomatitis that may become granulomatous. Gums are commonly affected with loss of teeth. And lymphatic form, cervical lymph node enlarged, tender, and adherent to the overlying skin and may lead to suppuration and sinus formation. So there is pulmonary form, mucocutaneous, lymphatic form, hematogenous spread may occur to the intestine, spleen, liver, and bone. Diagnosis the same as blastomycosis, KOH examination and culture. There is, but here the KOH examination, rounded refractile cells with multiple budding. Rounded refractile cells with multiple budding. And the culture slower growing and fewer spores than blastomycosis dermatitis. The treatment is ketoconazole and itraconazole. So this is the deep fungal infection. Lastly, the opportunistic mycosis. The opportunistic mycosis, there are two. Here, the cryptococcosis and the mucormycosis. To the left, the cryptococcosis, and to the right is the picture of the mucormycosis. So the opportunistic infections, actually not only these, but there is this the main cryptococcosis and mucormycosis, aspergillosis, and candidiasis. These are the most important opportunistic mycosis. Now we will talk about the cryptococcosis. The cryptococcosis here in this diagram is caused by Cryptococcus neoformans, and it is in encapsulated yeast. It is present in the pigeon excreta, creatine, and it is a neurotropic organism, especially on CNS. It's very important in AIDS patients, and the prophylactic and treatment of it is intravenous fluconazole. Why? Because it's the only one that crosses the blood-brain barrier. So this is the cryptococcosis in brief. What about the mucormycosis or zygomycosis? Mucormycosis or zygomycosis. It's internal medicine case. One of them is the rhino or mucorpus species, and there is fever, coma, diabetic acidosis. It occurs in leukemia and low cell-mediated immunity. Also similar paranasal sinuses, cavernous sinus thrombosis. It affects blood vessel wall and thrombosis. So the mucormycosis, it's a multi-system disease that occurs in usually in immunocompromised patients and with many clinical pictures. Now we will see the cryptococcosis. As we said, it is etiology Cryptococcus neoformatis. Occurs as saprophytic yeast from soil enriched with pigeon excreta due to presence of creatinine, and also usually from inhalation, affecting primarily the respiratory tract and marked predilection to the brain. It's a neurotropic organism, so there is a marked predilection to the brain and meninges. Although sometimes skin and other organs may be affected, epidemiology worldwide between males between 30 to 50 years old, and predisposing factor impaired cell-mediated immunity, lymphoma, carcinoma, treatment with systemic steroids, or treatment with cytotoxic drugs, and AIDS. Very important, the AIDS, and maybe the underlying disease. The cryptococcosis occurs in 3 to 12% of AIDS patients, mainly in the form of meningitis. So clinically, there is pulmonary disease, fever, cough, dyspnea, weight loss, and chest pain. And there is the meningitis, the most common presentation, headache, fever, nausea, personality changes. Sometimes there is mucocutaneous lesions, 10 to 15% of cases. Usually commonly company disseminated disease, like erythema nodosum-like lesions, acneiform papules and pustules, or warty-crusted plaques, mainly around the nose and mouth. Ulceration may occur leading to BC-like ulcers. The diagnosis: direct microscopy of Indian ink mouse, culture and histopathology, culture of sputum and CSF or tissue, and histopathology. We see encapsulated budding cells, serological test of CSF, and the treatment is the amphotericin B intravenously plus flucytosine, and more important is, especially in AIDS patients, the fluconazole, which the only one that causes crosses the blood-brain barrier. So this is the cryptococcosis, one of the opportunistic organisms. We can see here clinical picture of the cryptococcosis, and here we can see India ink preparation of cerebrospinal fluid, where there is encapsulated budding cells. And the second disease, opportunistic, is the mycorrhizasis or zygomatosis. It is a severe fulminating fungal infection affecting lung, CNS, paranasal sinuses, GIT, skin, and other parts of the body, caused by species as Rhizomucor and Rhizopus. Commonly affects severely immunocompromised patients, especially leukemia, diabetes, renal failure, and infection acquired usually by inhalation of airborne that settle in paranasal sinuses and lungs. There is cutaneous mucormycosis, usually with the disseminated disease, appears as painful erythematous eruption with varying degrees of necrosis, invasion of blood vessel wall, subsequent thrombosis, formation black necrotic debris in the main pathologic event of the disease. Direct inhalation may occur rarely with contaminated bandages and dressings. There is subcutaneous zygomatosis, and the diagnosis is the biopsy, and we can see broad and non-septate hyphae extending into blood vessels. So we can see the hyphae in tissues. Therapy is intravenous amphotericin. So this is the mycorrhizasis clinically, and the diagnosis by biopsy. We can see here the hyphae in the tissue.